Thank you. Today I will be talking about multimodality imaging in acute aortic syndromes. I have the following disclosure to make. Today I will be covering the role of imaging in the diagnosis and treatment planning of acute aortic syndrome, specifically talking about the role of chest x-rays, echocardiography, computed tomography, angiography, and magnetic resonance angiography in the workup of patients suspected of or known to have acute aortic syndromes. The learning objectives for this presentation will be to help you recall the imaging findings of acute aortic syndromes, identify mimickers of aortic dissection, describe the role of imaging in the management of patients suspected or known to have acute aortic syndromes. So, by far the most important role of imaging in the evaluation of patients thought to have acute aortic syndromes is to establish the diagnosis, to either confirm the presence of an acute aortic syndrome or to exclude it. Once an acute aortic syndrome has been diagnosed, the next step is to classify the acute aortic syndrome, and then the last role for imaging in the management of these patients is to identify complications that will impact the management of the acute aortic syndrome. So we'll start by looking at the role of chest x-rays in patients that present with chest pain that could be due to acute aortic syndrome. We all know that chest x-rays are performed routinely in the emergency department in patients who present with chest pain, and with respect to acute aortic syndromes, unfortunately, many of these are just like the patient here. The chest x-rays are completely normal. And in fact, there was a meta-analysis that was published in 2004 that described a very wide range of sensitivities and specificities for chest x-rays in the detection of acute aortic syndromes. And the sensitivity and specificities were so broad that the conclusion, the recommendation of this meta-analysis is that chest radiography is of limited value in diagnosing the acute aortic syndrome, and routine chest radiography should really be replaced by tomographic aortic imaging. That being said, I think that we will continue to see chest x-rays performed in patients who present with chest pain, and I think not necessarily to rule out aortic dissection, but to help detect any other potential causes of acute chest pain. Now, there are some findings on chest x-ray that we need to be aware of that would lead us or make us more suspicious of acute aortic syndrome. Specifically, findings that are related to the presence of mediastinal hemorrhage, aortic aneurysm, or such. And the first finding that we're going to look for is the position of the trachea. In patients who have aortic arch aneurysms or mediastinal hemorrhage from acute aortic syndrome, the trachea will frequently be deviated to the contralateral side. So in this patient with a large aortic arch aneurysm, aortic dissection, there is deviation of the trachea to the right. Another finding of indicating mediastinal hemorrhage, potential acute aortic syndrome, is mediastinal widening. Now you have to be careful because frequently these radiographs are done portably in the supine position, and the mediastinum can be artificially widened just due to the portable and supine technique. In a patient who presents with the appropriate clinical scenario, the presence of mediastinal widening should make you more alert and suggest potential evaluation with cross-sectional imaging. We can also see obscuration of the aortopulmonary window due to hemorrhage extending between the aortic arch and left pulmonary artery. And if there's hemorrhage extending along the cervical vessels, you can also see thickening of the paratracheal stripe, like in this patient that had an aortic dissection that resulted in fairly extensive mediastinal hemorrhage that extend up into the upper mediastinum along the left subclavian and left common carotid arteries. We have a very thickened left paratracheal stripe. And then the last radiographic finding that I'll describe for you and show you in this case is the displaced intimal calcifications. Sometimes this can be difficult to discern if these are truly intimal calcifications or if these are simply calcifications of thrombus within an aortic aneurysm. But if you have any comparison studies showing the position of the calcifications up along the outer wall of the aortic arch, and now in the current exam they are displaced from the outer wall, it's a fairly classic sign or indicator of acute aortic syndrome. And in this particular case, the patient had intramural hematoma. That takes us to echocardiography. Echocardiography has a very important role to play in the workup of patients with suspected acute aortic syndromes. Echocardiography is portable, it's inexpensive, and in the case of transthoracic echocardiography, it's non-invasive. That being said, a negative transthoracic echocardiogram does not exclude the presence of acute aortic syndrome because of the decreased sensitivity in evaluating the descending thoracic aorta. Transesophageal echocardiography, very accurate, similar accuracy as CT and MR angiography. However, it does require the placement of an echocardiography probe into the esophagus, so it is a little invasive. It is, however, a critical adjunct in the repair of patients with type A aortic dissections, particularly in the detection of some of the complications we see with type A aortic dissections, including aortic insufficiency, pericardial tamponade, etc. Now, before I talk about CT angiography, I just want to briefly touch on the role of MR angiography in a meta-analysis that was published almost 10 years ago. The sensitivity and specificity of MR angiography was excellent, both of which were 98%. So it is a very good imaging modality for the evaluation of patients suspected of acute aortic syndrome. And in fact, if you've got patients that cannot get intravenous contrast, either CT contrast or MR contrast, there are very good non-contrast enhanced MRA methods that are very, very quick, including the single shot steady state free precession images that you see in the middle and bottom right images. So that brings me to CT angiography, and this has really become the reference standard that is used to diagnose and evaluate patients with acute chest pain that could be due to aortic dissection. It's very rapid. Most emergency departments now have CT scanners in the emergency department, and most importantly, you can very confidently exclude the diagnosis of aortic dissection, penetrating atherosclerotic ulcer, or intramural hematoma with a negative CT scan. So that brings me to the acute aortic syndromes that we're trying to diagnose. There are three main types of acute aortic syndrome. I kind of think of them as being on a spectrum. The first that I want to talk about is intramural hematoma. These two images here are two different patients, both of which have intramural hematoma. The patient on the left has an intramural hematoma involving the ascending and descending aorta. The patient on the right has an intramural hematoma involving just the descending thoracic aorta. And you notice that in both of these cases, we see crescentic thickening of the aorta. It's relatively intermediate attenuation on these CT angiographic images. And in this particular case, both of these patients ended up having intramural hematomas, but just on the basis of the CT angiographic images, you can't differentiate with 100% certainty between an intramural hematoma and a dissection with a completely thrombosed false lumen. And that's part of the reason why most rule out aortic dissection protocols include non-contrast imaging. And on these non-contrast enhanced images, we can very nicely see the high attenuation within the wall of the aorta due to the intramural hemorrhage. The next acute aortic syndrome that I want to discuss very briefly is penetrating atherosclerotic ulcers. These penetrating atherosclerotic ulcers always occur in and around an atherosclerotic plaque that becomes inflamed, results in disruption of the intimal layer of the wall of the aorta. We can see hemorrhage within the media adjacent to the atherosclerotic ulcer. There's also some hemorrhage in and around the wall of the aorta, indicating that this is a very active inflammatory process. And in distinction to the aortic dissections, these penetrating atherosclerotic ulcers are very localized. They're not always aneurysmal, but we do see a sort of a discrete neck between the true lumen of the aorta and this little outpouching where the ulcer has occurred. Here's two more cases of penetrating atherosclerotic ulcers, and again you'll notice some of the same features that I've just described in the previous two cases. Very localized, saccular outpouching next to an atherosclerotic plaque. There is hemorrhage in and around the atherosclerotic ulcer in the wall of the aorta. These can be associated with other signs of rupture, like in the patient on the right that has a very large right hemothorax. Now finally, the third acute aortic syndrome that we are evaluating for is the aortic dissection. And in these two images, we have two examples of a acute aortic dissection involving the ascending aorta, and you'll notice that we have a discrete intimal flap separating the true and false lumens of the aortic dissection. The intimal flap, which is made up of the intima and a portion of the media, is in the acute setting very mobile, and so it has this very serpiginous look to it. And frequently the aortic dissections, as they propagate distally, they will spiral around the aorta. It's very important to not mistake cardiac motion artifact from a true aortic dissection. For most places, they rule out aortic dissection protocol, does not include cardiac gating, and so as a result, you can get this pulsation or motion artifact in the ascending aorta, particularly in the proximal ascending aorta at the level of the aortic root. And this is very distinct from the serpiginous intimal flap that I showed you in the previous slide. The intimal flap that we see in aortic dissections is going to spiral as it propagates distally, and it looks very distinct from the motion artifact that you see in these two examples here. And again, just to re-emphasize the differences between the cardiac motion artifact and a true aortic dissection, here are two more examples of aortic dissection involving the ascending aorta. Both of these were done without cardiac gating, and the true intimal flap that we see in both of these examples is very distinct from the pulsation artifact, the cardiac motion artifact that we saw in the previous slide. So once we've confirmed the presence of an acute aortic syndrome, there are certain things that we have to comment on that will help us classify the acute aortic syndrome even further and help guide management. And the most important characteristic to describe that will help determine how we're going to manage the acute aortic syndrome is to determine whether or not the ascending aorta is involved. Dissections, intramural hematomas, penetrating atherosclerotic ulcers that involve the ascending aorta are all going to be treated emergently because of the high risk of rupture and death without treatment. That is in contrast to acute aortic syndromes that do not involve the ascending aorta. When the ascending aorta is not involved, the data supports initial trial of medical management, first to help stabilize the acute aortic syndrome, and many of those patients will not require surgical repair. Other features of the aortic dissections in particular that the surgeons like to know about prior to deciding how best to treat their patients is the presence and location of intimal tears, the extent of the aortic dissection. It's very important to differentiate between the true and the false lumens, and identifying which branch vessels come off of the true and the false lumens, and as well as whether or not the dissection actually goes into any of the branch vessels. So the patient on the left of the screen presented with abdominal pain because the dissection extended into the superior mesenteric artery, and the patient on the right of the screen actually presented with a stroke because the right common carotid artery was completely occluded by the dissection that had extended into the right common carotid artery. The final topic that I want to cover is the identification of specific complications that will help sway management from either medical to surgical or vice versa. And probably the most important of these is whether or not there are any signs of end organ ischemia. And the kidneys in particular can be quite susceptible to hypoperfusion when the dissection involves the renal arteries. And that can be due to either extension of the dissection into the renal artery and occluding the renal artery, or it can be a dynamic phenomenon. For example, if the false lumen causes the intimal flap to obstruct the origin of the renal artery. And so in this slide here, I'm showing you two examples of patients that presented with acute renal injury due to hypoperfusion because the aortic dissection involved and extended into the renal arteries. The patient on the left of the screen had left renal ischemia, and the patient on the right had right renal ischemia. Another important complication to describe, if present, is the aortic insufficiency, aortic regurgitation, that can occur in patients with aortic dissections of the ascending aorta. And as I mentioned previously, this is usually detected with echocardiography. It's part of the routine workup and the evaluation of the patients in the operating room in preparation for the ascending aorta dissection repair. But this is something that you can also see with CT or MR. On the right of the screen, this is an example of a patient that we scanned a few years ago when cardiac gating was done only with retrospective cardiac gating. This was before prospective cardiac gating was available, and so we routinely gated, at that time, we routinely gated our CT angiograms using retrospective gating. And in this particular example, you can see prolapse of the intimal flap through the aortic valve during diastole. It's also important to note whether or not there are any signs of hemorrhage or rupture secondary to the aortic dissection. Sometimes we can see frank rupture directly on the CT angiographic images. The patient on the left of the screen, there is active extravasation into the posterior mediastinum, and then this patient on the right is one that I showed you before, penetrating atherosclerotic ulcer that had ruptured into the right pleural space, giving us a hemothorax. So in summary, the workup of patients with acute aortic syndromes depends immensely on imaging, including chest x-rays. They're very quick. There are some findings that can suggest the presence of an acute aortic syndrome, but it's really not accurate enough to rule it out or rule it in with enough accuracy. And therefore, really the diagnosis and management of patients of aortic dissection relies on cross-sectional imaging, whether it be echocardiography, which is very accurate, portable, and critical to the intraoperative management of patients with ascending aortic dissections, CTA, which is really the reference standard that is used routinely, or MR angiography in patients who would not be candidates for either CTA or echocardiography.